I've thoroughly enjoyed it. And one of the things I really gravitated toward, which is fed that, is congenital anomalies. And I really have enjoyed over the years, whether it's bone dysplasia, cardiac anomalies, airway anomalies.
Hello, Dr. Richardson. Thank you so much for joining us. On our last installment of eShadowing, you have the, I don't know if it's lucky or unlucky, honor of being our last guest. You get to close us out here on eShadowing. We've been going for a couple of years since COVID, and it's time to move on. So thank you for joining me today.
Okay, yeah, good to be here.
And all of us. So we're going to be talking about radiology, specifically pediatric radiology, if my internet sleuthing is accurate.
Yes.
How's that sound?
That sounds great.
All right. Do you have a presentation for us or not?
I do. I had a couple of cases to show.
Cool.
That would be, so I put that together.
Okay. So why don't we have a little bit of a conversation first about the specialty, how you got there, and then we'll jump into some cases near the end and hopefully have some time for some Q&A.
Okay, sounds good.
All right. So before we start, to make sure if you're watching or listening to this, switch over your chat to everyone from hosts and panelists and let us know where you are watching from. Say hello to Dr. Richardson and let us know if you're interested in some radiology. So for you, Randy, how did you get into this world of pediatric radiology?
Yeah, that good question. In medical school, you have to choose a specialty, as you know, and during my first year, I got involved in some research doing anatomic radiology, so a radiological anatomy sort of course that we're developing to identify, anatomy structures on some imaging studies. And I worked with a resident in radiology at that time, and we just kind of clicked for me. I really enjoyed anatomy. I enjoyed the diagnostic piece of it, trying to figure out, what's wrong with somebody based on imaging. I went through my third and fourth year, and I kept changing my mind about what I wanted to do, but radiology was always in the back of my mind, and that's what I ended up doing. And I really always liked pediatrics too. So when I finished my radiology residency, I did a fellowship in pediatric radiology. And so my two worlds came together perfectly.
When you said you were going through kind of your third, fourth years, kind of flip-flopping back and forth, what were those other specialties that were kind of taking the lead every now and then?
Yeah, pediatrics and surgery, and specifically pediatric surgery are the two I really kind of liked. I dabbled with the idea of emergency medicine. Let's see, and those are kind of the main ones, but pediatrics, radiology, and surgery.
Was there anything about those other specialties that just you were like, this is why I'm not choosing you?
Yeah, I remember in OBGYN, I actually kind of liked OBGYN.
I loved OB. There was just something about that patient population and the anatomy, physiology that was like, this just clicks with my brain.
Yeah. The only thing that I didn't like about it was that, a woman would say, no, I don't want a male student. And so I said, I don't want to go through my whole career going, oh, no, not the guy. Don't bring him in here,
Yeah.
So, let's see, the other ones, internal medicine, I don't know. I just, that never really clicked for me. A lot of rounds, a lot of talking is desirable to me. I don't know.
It's too cerebral. I just need to do. I always picture radiologists being the kids that got the highlights magazines at home doing the object find. Was that you growing up?
I liked puzzles, like those sorts of things. And I think it's just like a puzzle. To me, radiology is a puzzle. You've got a problem, you've got a clinical scenario, and you've got to try and figure out what it is based on imaging. And to me, that really appealed. So, as a kid, I liked, I don't know, I liked games, I like puzzles, I like those sorts of things. So this seemed to fit nicely for me.
Yeah. What's one of the biggest misconceptions about radiology that you're constantly fighting amongst other healthcare professionals or residents or students coming up?
Well, my wife will say that I'm not a real doctor, right? Because you don't do real doctor things. You don't see patients and prescribe medications typically. a lot of people think you're a radiology tech. Oh yeah, I've got a cousin. He went to a 9-month course and now he's a radiologist too. I just learned to live with it. I just roll with it. I said, oh, that's awesome. Yeah, maybe I know him. Whatever. So yeah, those are probably the two. My mom for years thought I was a radiation oncologist. She would say, "Oh, isn't it so sad to see those kids with cancer?" I was like, yeah, it's really sad, Mom.
Yeah. And for you specifically, you are a diagnostic radiologist. So you aren't an interventional radiologist. You're not at the bedside doing procedures and stuff for the most part, correct?
I did actually do interventional for about a year after I finished fellowship. So during a fellowship, you do a little of everything. So I did a couple of months of interventional and felt pretty comfortable doing it. So when I came here to Phoenix, actually, I did that for a year. And then I moved into education and kind of saw that as my path and I've loved it ever since.
Yeah, awesome. What do you like the most about your day-to-day job?
I really like the interaction with learners, with students, with residents. It's one of the reasons I left kind of a private practice and came over to an academic medical center, is to work with residents. And I've been teaching residents and students ever since. I really gravitated to that aspect. I became a program director, chair of the department, and so on. And now I'm a dean for the School of Medicine here in Creighton.
Awesome. What do you like the least?
There's downsides to all specialties. There is no perfect specialty. I think the maybe how removed you are from the patient. I think I enjoy the interaction with moms, and that's why I went into pediatric radiology. There is a little bit more interaction with patients. You do a few more procedures, upper GIs, and those sorts of things. But I did like interacting with patients and parents and that sort of thing. And you get very little of that as a radiologist.
Yeah. For students coming up through training now, whether they're pre-meds, going to start medical school soon, or they're in medical school, there's lots of chatter out in the world about artificial intelligence and machine learning and what jobs is it coming for. I've had this conversation with lots of radiologists that it feels like we're not scared at this point that radiology is going away anytime soon. What is your future outlook as a career for radiologists with technology kind of continuing to grow at exponential leaps and bounds every year?
Yeah, I think technology, in my experience, creates more jobs. I just think so far, technology has improved what a radiologist does and how quickly we can do it and how efficiently we can do it. Going through films on a light box, one after the other was
how archaic.
Oh my gosh, it was
like, why won't it stick up there?
And just how much more efficient we are now. But with that efficiency, we've seen a huge increase in the number of studies.
It's this what do you call that? Induced demand, right? Whenever you widen a highway, you're like, oh, the roads are going to be empty. No, everyone starts driving on it.
Everybody needs a CT now. Everybody needs a sound, and so I remember in my fellowship, it was kind of a busy day, and they had films. It was kind of a busy day when you had 3 or 4 CTs on kids, right? That was a busy day. Yeah, that's an hour's worth of work now. Not even an hour. I mean, that is nothing. And so just the number of studies has exponentially increased. And AI might even make it faster, right? Yeah. It might make it more efficient where you can not have to look at, for the small, tiny nodules and all throughout the lungs. That AI already does that for you. Now you just interpret which ones are suspicious or not suspicious. And that's the way I see AI going. It's going to be another tool that we can use that makes us better.
Yeah,
voice recognition made us better. The PAC system on the computer made us better. And this is going to be another step.
Yeah. So adjunct, not replacement.
I don't think so. We've had AI for a long time.
Yeah.
We've been using computer-aided diagnosis for detecting calcifications in the breast for, 2 decades. So, it just makes us better, I think.
Yeah. What does the training path look like to become you?
So, you go to medical school, you are actually a doctor, right? You do go to medical school. Then it's a 5-year residency and a 1-year fellowship. So, and the 5-year residency includes an internship. So you do an internship and it's 4 years of radiology, then another year of fellowship in pediatrics. And that's still the pathway. So exactly what I did is what everybody still does now.
Yeah. If you had to do it all over again, would you still be a pediatric radiologist?
I definitely would. I've thoroughly enjoyed it. And one of the things I really gravitated toward, which is fed that, is congenital anomalies, and I really have enjoyed over the years, whether it's bone dysplasia, cardiac anomalies, airway anomalies, just a variety of different anomalies that occur in infants has been something I've really quite enjoyed.
How much do you do in utero?
I do a fair amount of fetal MRI, not a fair amount, one a month kind of thing. And that's interesting. You can't do as much because you can't use radiation sort of modalities. So a lot of MRI though, a lot of 3T MRI work being done with fetal MRI, which is really quite interesting. And what you can diagnose is quite amazing. So.
Yeah, that's awesome. And what they're doing with in utero surgeries.
Right.
I forget it wasn't this country. I don't think they did a spina bifida surgery in utero, which was crazy. But awesome. I would love to jump into some cases if you want to start sharing that.
Yeah. So let's see. Share screen. Let me open this up. Can you see that?
I can.
All right. So, I just thought I put in a couple of real basic cases, but, this is a film from maybe a week ago or 2 weeks ago, little NICU baby. And this is kind of what I do every day. I come in and go through the NICU films and see what their kind of anomalies. So this is a kid that's been in the NICU for a couple of months now, and you can see that sort of coarse interstitial markings in the lungs, maybe a kind of a bubbly look to the lungs. So he's developing chronic lung disease or bronchopulmonary dysplasia. And interesting, what happens with that is the lungs kind of become hyperinflated and push the abdominal contents downward, right? So you get that downward motion of the diaphragms, and they often have a patent process of vaginalis. So here you can see this big hernia. So an inguinal hernia. Just from that pressure, and it's actually quite common in these NICU babies that are here for a long time and develop chronic lung disease. That chronic downward motion on the diaphragms will give them these hernias. So kind of just a nice basic case. You can see all the lines and tubes that we meticulously try and follow and make sure they're in the right place. So we have an enteric tube, an endotracheal tube, which is a little high, kind of right at the thoracic inlet. PICC lines coming down here, right in the kind of the cavo-atrial junction, but a really typical sort of morning film that we would read on a little baby. So it's one of the things I do is I take care of the NICU babies and make sure that everything's looking okay for them.
How would their lungs look a couple months after being discharged from the NICU? Do those lungs start to heal up?
Amazingly enough, they still are making lung cells. And so often what happens is the bad lung gets squished out by the good lung, and they look pretty normal. And so a few months later, hopefully that is the scenario. Now it could be like an end stage lung disease, and they have struggled with lung problems their whole life, and that's possible. But often they actually do pretty well.
Yeah, that's awesome.
Yeah. So another thing we can do is give people contrast and watch what happens as they drink. And this is kind of a common swallow study we do in a little baby, or this is maybe a little older kid that's not having problems feeding, right? You can't, when he drinks, he coughs a lot, or maybe goes desaturates, has decreased oxygenation. And so they do this study to see if there's aspiration. And so here you can see the little clip of them swallowing, and you can kind of stop it right here. So here's going into the hypopharynx, filling up piriform sinuses and vallecula. And then hopefully everything goes straight down the esophagus. And here, as we're going, you can notice that some of it went forward and down. That's in no man's land. That's not where we want it to go. That's going down the trachea. As you kind of watch that real time, you can see that forward motion of that contrast going right into the through the vocal cords and down into the trachea, and a nice example of aspiration. So as you introduce contrast, you can see some things better, and this is a nice example of being able to see the contrast, fill the pharynx and then the esophagus, and then go inappropriately forward into the trachea here. You can see it kind of layering into trachea there at the bottom. So just another example of some kind of basic studies that we do.
Who is ordering this test, this specifically the swallow test, and what do you convey to them to hopefully help the patient in this situation?
So usually it's the neonatologist that'll order this test because the baby's desaturating with feeds or coughing a lot, or if there's some sort of a problem with feeding the baby with a bottle, right? And so they want to make sure that there's not what we found here, which is aspiration. So they would do this study to sort of rule out aspiration. And there's kind of three basic things that we see commonly. One, if we just stopped it right there, a little contrast going forward and back, we call that penetration. So it's kind of penetrating the cords, but it may not go down into the airway. And nobody knows exactly what to do with that. And so we worried about it a lot, but that's certainly better than aspiration, which is the rest of this, which is going down into the trachea there. You can kind of see it squeezing down. And then the other thing that we see frequently is some nasopharyngeal reflux. So instead of it staying in the oro and hypopharynx, it goes back up into the nasopharynx. And that's when they'll be a real noisy eater, where a lot of the contrast or whatever they're drinking is going up into their nose, basically. And so they'll have problems breathing while they're eating. So it's kind of the three basic things we look for.
And for the students, hopefully they've seen this. If not, it's a stuff of nightmares. Babies' skulls with all of the teeth there. I'm assuming what I'm looking at, some of those more dense areas, those are the teeth that are kind of hiding in the skull, waiting to come out later in life.
The permanent teeth up there.
It's so gross. Yeah, if you guys haven't seen a skull of an infant, Google it and just see all the teeth just waiting.
Very good. Another kind of pretty basic study. You get a kid with projectile vomiting. So maybe this kid's a few weeks old, and he drinks, and he's not growing, he's not gaining weight like he should or she should, and the mom or dad describes projectile vomiting. So when they throw up, it just shoots out, right?
Pathognomonic.
Yeah, really, it is what it sounds like, right? And so this is a contrast study they did in a baby. You can see this, they call it the caterpillar sign. So the stomach is kind of has that bulging areas, and it's the hyperperistalsis of the stomach. And it's trying to push through this pyloric region, which is super narrowed. So this is what we call hypertrophic pyloric stenosis. And that's exactly what's happening, is that hyperperistalsis. It's trying to squeeze through the obstruction, and instead it goes up where there's an opening, which is back up the esophagus and out the mouth. And so this is a nice example of hypertrophic pyloric stenosis. We don't do it this way. We don't make the diagnosis this way anymore. Typically we do an ultrasound. And so there's an ultrasound of a baby with hypertrophic pyloric stenosis. And now you can see the thick walls of that pylorus. Go back just a touch. Here's really thick wall. And you can see all the gunk in the stomach here. We gave him a little water, but there's just kind of mixing around of all this stuff in the stomach. And it's trying like crazy to push through this pylorus, but it just can't do it. Nothing's going through. And instead it's going back up the other way. So this is the typical way we make the diagnosis now, is we look at that pylorus, and measure the wall thickness. If it's thicker than 3.5 millimeters, usually it's going to be elongated as well, greater than about 14 millimeters. And that's how we'd make the diagnosis now, instead of doing the fluoro study and radiating them. So, you know, ultrasound has that advantage of no radiation. Maybe it's some more advanced imaging. This is kind of an interesting case to me. Little baby that had just masses all over the neck, under the arm, and it really wasn't a diagnostic dilemma here. These are lymphatic malformations. They're full of lymph, white sort of milky substance, but it was pushing on the airway, and so the baby couldn't breathe. And so they had to intubate the baby, and they couldn't extubate the baby from the mass effect from these masses. So they did an MRI, and here you can see all of these fluid-filled structures, these lymphatic malformations. And you know, the surgeons want to cut everything out, and so they did their best to try and remove this. And sometimes when you can't get them all, it just makes them angry, and they get inflamed and bigger, and it made the problem even worse. And so that's actually what happened. And so they came to us with a request that we do something called sclerotherapy. And so sclerotherapy is where you'd stick a catheter in these cysts, you'd suck out the fluid, and then you'd put a sclerosing agent into the cavity, and it kind of burns the walls. And you let that sit there for a while, and then you take that out, and it adheses together. So the walls that are raw now kind of adheres together. And the surgeons are making fun of us. They're like, that's never going to work. We got to go cut them out, you know. And so that's what we did over a 2-week period. We put catheters in these cysts, and we'd go through that process of sucking out the fluid, putting it, I think we used doxycycline as our sclerosing agent, put that doxycycline in there, wait about an hour, then suck it out. And sure enough, they started to heal. They started to close off enough that we extubated the patient, and the patient was able to go home. So
Wow.
I remember the surgeon was giving me a hard time. He called me about a year later from Peru. He said, hey, you remember that one case, you know, we did, we couldn't get it out because he had another patient just like this, and he did the same thing we did. So it was sort of
You were right. I was wrong. Wow. I didn't know surgeons were capable of that.
Little humility at times. Only pediatric surgeons. So.
Oh, that's right. Yeah.
There's my last case. So here's a kid that comes in with stridor. Can be a tricky thing, and we often want to rule out a vascular ring, and this was a little suspicious in that there was narrowing of the trachea here. And a good screening tool for a vascular ring is actually just an esophagram. The esophagus is soft and squishy, so if you have a vascular structure surrounding it, you'll see the indentations on the esophagus. And so we see nicely here the indentations on that esophagus. So we were suspicious there was a vascular ring. And so then we did a CT scan, and here you can see nicely, we talk about what side the aortic arch is on. And, it's either a right-sided aortic arch or a left-sided aortic arch. And here the problem is there's two aortic arches. There's one on the left and on the right, and they split and then they come back together. And so this is what's called a double aortic arch. And so something I've spent my career doing is taking this anatomy from these slices of a CT scan and using the computer to create a 3D reconstruction of it and color coding it to make it easy to look at and tell what's going on. So here I did exactly that. I made a 3D model of all those slices so you can see much better what's going on. So here you see one aortic arch on this side, on the left. You see another aortic arch on the right. You can see how they come back together. And the structures in the middle are getting pinched. So this is the airway in yellow, and it's getting squeezed in that double aortic arch. And there's the esophagus is in green, and it gets pinched in there too. And then you can you can do whatever you want with this anatomy. You can take away the and just show the airway. So here's just the airway, and you can see what's happening to that airway. It's just getting squashed between those two aortic arches. So this is a kind of a classic vascular ring that we talk about. And then the last step that we've done is now you can print these things. So here's this case. there's the aortic arch on one side, the aortic arch on the other side, and you can see the airway in yellow in the middle. And you can print this and show it to people, show it to mom or dad and say, well, here's what the problem is. It's got two aortic arches. This is a vascular ring and it's squeezing the trachea in the middle. And so that's kind of the final step that we've done for quite some time now. So something I've really enjoyed. I've written a few books on congenital anomalies and 3D printing and 3D modeling, which has been a lot of fun to me. So
it's gotta for patient education, that 3D modeling and then printing so they can tangibly hold something and not just see it on a kind of a 2D computer screen. That's got to do wonders for that communication between physician and surgeon who you're handing this off to and that patient, for them to really understand what's going on and feel like they're a part of the decision making potentially. You
couldn't have said it better. And I've literally had parents say, this is the first time I've ever actually understood what was wrong with my child. You talk about a transposition of the great arteries, and you're looking at these complex echocardiograms that nobody but the cardiologist understands what's going on, right? And you put it in a 3D model and say, oh, here it is. The right ventricle is connected to the aorta and the left ventricle is connected to the pulmonary artery. And I've literally had parents go, that's the first time I've ever understood what they were talking about. So education has been huge for parents, but not just parents love it. The pediatricians love it, the cardiologists love it, the surgeons love it. It's quite a nice tool for them to be able to look at things differently. You can even print it in flexible material and hollow it out. And surgeons can actually practice doing the surgery on the model before they do it on the patient.
Yeah, that's fantastic. You can print to scale, print in, and I'm a huge fan. I don't have my own 3D printer yet, but I watch so many videos of 3D printing and different materials that they're using. It's really cool what we're able to do now.
Yeah, if you can see my office, I have hundreds of little models of baby hearts all over my office.
That's awesome. Yeah. I would love to open it up for some Q&A. If any of you have questions, you want to raise your hand, we can allow you to come on and ask some questions with Dr. Richardson. Looking at your career as it's changed, what do you think is going to be the biggest driver of change moving forward?
Well, I mean, AI obviously is the answer to that, and how that's going to be used. I think there's a lot of politics involved. There's a lot of self-interest involved, some fear involved, but figuring out how to effectively use that as a tool to make us better, I think is something we've already talked about. The biggest drivers I've seen over my career are actually what happens in the politics. You see some political movements where healthcare has been a big issue, and they want to say we're going to use less subspecialists, more primary care. Those are the times when the market for radiology went through the roof, and there just wasn't enough radiologists. Because when you drive primary care, those are the physicians that rely on a radiologist more. Yeah. And so the need for them went, Hillary Care and Obamacare are the two examples I could think of, and maybe that's not the right names for them, but those are the two times when the demand for radiologists went through the roof, and there just wasn't enough of them. So I think that's been interesting over time too. So what politics does to your profession, it's real, and it really does affect demand in certain ways.
Yeah. Do you get involved in that world, or do you just kind of like, I'm here, I'm practicing, whatever's going to be is going to be, and I'm just going to take care of my patients the best way I can?
I've gotten involved somewhat in it, mostly more personal things. Prop 308 here in Arizona, we got heavily involved in the Dreamers and allowing them to pay in-state tuition. But things like PA, we talk about physician assistants and radiology physician assistants. What can they do? What can't they do? Can they do fluoroscopy? Can they not? And so, yeah, I've been involved in some of those areas they're more radiology sort of centric.
Yeah. question here from a student. How do you handle the emotional aspects of your job, such as delivering difficult news to patients and their families? Yeah, how much for you as a radiologist, how much is that direct communication, or are you handing off to the treating physician to make those have those conversations?
So a radiologist really, my customer is the doctor.
Yep.
A doctor sends me a patient to try and figure out what's wrong with that patient, and I report back to that doctor, right? So I rarely go in and give bad news to a patient. Now, if the mom and dad are in the room I talk to them, I tell them what I saw and what I'm going to put in the report. But like for a big tumor or something like that, I probably wouldn't sit down with the parents. I would let the treating physician do that, but I would make sure I communicated with them. So it's more, my customer really are other physicians.
Yeah. Excuse me while my eyes watering up the wazoo. And a lot of that is just for students watching, right? A lot of that, I'm assuming, is the general idea that you as the radiologist, you're not going to know the intimate, right, plan of care, right? What are those next steps that need to be discussed, right? You know what you're seeing, but it's the oncologist, the surgeon, the whoever that's going to know, okay, great. Now that we know what it looks like, here's what we're going to do.
And I think pediatricians, especially, and pediatric subspecialists are some of the best at working in teams. So I've always felt like I'm part of the NICU team. I'm part of the cardiac congenital heart team. And so, we do work together, and we often do approach moms and dads and explain things together. And so that's been very satisfying over the years, where I think a lot of the other specialties in radiology don't do that. An exception would be women's imaging, mammography. They are very heavily involved in with the patient. But a lot of the other specialties don't do as much of that. And I think pediatrics, that's been very satisfying to me to be part of that team.
Yeah. If you could wave a magic wand and fix whatever it is about your specialty, what do you think you would want to change?
About my specialty, let's see. Well, probably the biggest issue I've seen over the years is what information is given to us. Often we get a one sentence, this is the problem, now figure it out, sort of thing. And we haven't had in the past access to the electronic medical record and other things. And that's starting to change, and I think it's improving. But that's been a sore spot for a long time. We're a little bit in the dark, so to speak, right? We don't get all the information that might be helpful to us to make a diagnosis.
Do you think that's such a common problem I hear all radiologists talk about? And I think a lot of consulting specialties in general, do you think that is a consequence of just poor education? How do we train these future physicians to be able to interact with their colleagues in other specialties? Or do you think it's a consequence of just not enough time on that physician's kind of plates to really take the time to go, hey, Randy, here's what I'm thinking, and here's what I see, and here's what the clinical presentation's like, and here's my differential. Can you help me out?
I think it's a multifactorial problem. Sometimes it's just how the system functions, right? So a doctor writes an order, puts it in the chart, and then a clerical person enters the order into the computer, and that transition, there's lost information, right? Or they just put the same thing every day for the same reason, like a chest X-ray. So I think that's one component of it. Another, time. Clearly, people are going on rounds. They're trying to do a lot of different things, and so that doesn't get a priority to them. The best way I've seen it work is really what I was talking about with working in teams. Our NICU doctors, if they're concerned about something, they call me and they talk to me. That's the best possible function of communicating directly. Hey, this is what I'm looking for. This is why I'm concerned about it. And then I call them back and we have a conversation. And I think a lot of that with technology gets lost, and it really is the most effective way to take care of patients. So, I know we try to create systems to take away those conversations. You don't have to spend time talking to each other. And I think that's why we fail sometimes, is that communication isn't very good.
Yeah. All right. So let's ask some questions here. Hello there. Ask to unmute. Candida? Hello.
Hi, hello.
Hello.
You, you actually pronounced my name right. Not many people do it. Hi.
What's going on? What's your question?
My question was, what's a typical day or like week for you as a radiologist?
Yeah, I think radiology is more regular hours for my practice. For a private practice, it's very different. So I'm more, 8 to 5 kind of day. We have residents and fellows who sort of cover at night for us, and we're on call. And so if they have a problem, they can call us and consult with us. So that's sort of an academic typical practice where you'd have residents and fellows on in the evenings covering while you're off. And so now private practice radiology groups, they cover 24/7, right? So they figure out how to cover. And so their hours are quite variable. They're going to have, a float week where they're on all week at night, or maybe they have a whole team that just float for the year. So it can be quite varied, your daily sort of routine of how long you're in the hospital and how long you're reading in the. But what I would typically do is I get there at 8 o'clock. I start looking at the overnight films that the residents read overnight, make sure that they were all appropriate. Then I start reading through the ICU films, any studies that were done. And then it's just a continuous flow of exams throughout the day. And it's a variety of studies from, chest x-rays, ultrasound, CTs, MRIs. It's just a variety of things, which is another nice thing to me is I like the variety of different types of imaging to be able to look at every day. And so, you do that for your day, and mixed in there, you have students and residents that come through, and I try and show them cases just like I did right now. I would do that with a student and a resident during the day. I would set aside some time to say, hey, let's look at a few interesting cases. We'd look at those cases, and I would have them tell me what they see instead of me telling them what I see, right? So it's sort of a quiz kind of thing, and that makes the day, to me, pleasant to be able to interact with learners.
Nice. Maya.
Hello. My question was, you talked about being an educator in your specialty, and I was just curious on how you developed the skills to become an educator, both to the patients as well as to others practicing in your specialty.
Yeah, I think first you have to learn your own specialty and be good at what you do. I think you can start with, presenting cases in conferences, multidisciplinary conferences where you would present the case, present the imaging findings. It really is a lot about telling people what you see. You're presented with a study. Well, what are the findings? What do you see? And then second, what do you think that might mean? So what could it be? So you put together a set of findings. What does that mean for the patient? And then what do you do about it, right? So what am I going to recommend based on what I found? And you do that over and over again, and we're tested on that, and that's part of becoming a radiologist. But then a big part of radiology is helping the physician that's ordered the study understand, right? And so you have that feedback loop that you give that. And I think in doing that, in closing that loop and helping whoever ordered the study understand what you saw, what you think it might be, and what you'd do about it, you're teaching, right? And then you take that set of skills and now you use it with students. And so you collect cases that are interesting and teach important lessons in radiology. You show the student or the resident the case, and you expect them to do what you did, right? To make the findings, to tell you what you think might be wrong, and then what you would do about it, if anything. And so that process of going through cases that way in time helps you to be an educator. And then you put sets of cases together on cardiac or on GI or GU, and then you give those as lectures. But I, rather than lecture, I really like that format of the interactive sort of way of teaching, where, you know, I show them a case and I expect them to do what I would do, right? To tell me what they see, what they think it is, and what they would do about it. I don't know, that's a long explanation.
Yeah. I'm interested, as we kind of wrap up here, kind of switching over to your role with Creighton as a regional dean. With the medical school there, most of these students watching right now are going to be applying to medical school here in the next several years, or next year even. Any thoughts, any advice for them, just from a pre-med perspective, on their future aspirations of getting into med school?
Yeah, I think you know, we're like a lot of medical schools in some ways, and a little different in some ways. And I think you know, do well in your classes, right? Get good grades. Do well on the MCAT, and that's what everybody will tell you, that, you know, the entrance sort of exam. But for Creighton, we really are kind of mission driven. We say, right? We one of our missions is to care for those in need. And so we like to see students who have a history of that they are out volunteering in our community. They're trying to help people, and they're showing leadership in those areas of leading others to help people in need. And so that's really one of the things we're interested in, is beyond just getting good grades and doing well on the MCAT, is what kind of person are you? You know, are you the kind of person that would fit our mission of trying to help others in need? You know, if you ask me what I'm most proud of, it's our partnership with St. Vincent de Paul, and going there and creating a multi-specialty clinic where people without insurance can access the best physicians we have for free. You know, and I think that service to the community is who I want to be known for. That's what I want our school to be known for, is that we're reaching out to people in need to try and help them with the best physicians available. You know, I love saying that the best physicians I know volunteer their time at St. Vincent de Paul. Nice.
Well, Dr. Richardson, I think our time has come to a close. Thank you so much for joining us on our last eShadowing. Perfect guest to close out here. For everyone that attended, thank you for coming and hanging out and learning about pediatric radiology.
Thank you
so much.
Glad to be the last.
Take care, everyone. Bye.